Hello, my name is Irene Bobadilla. I will be doing my article critique on parent-child interaction therapy as an attachment-based intervention, theoretical rationale, and pilot data with adopted children. So, just a little background on parent-child interaction therapy, or PCIT. It is a widely recognized evidence-based therapy for children with externalizing behavioral problems that teaches parents to provide positive attention to the child's desired behaviors and implement nonviolent consequences when needed. PCIT is unique among parent training programs because of the live coaching in session that the caregiver receives from the clinician. Didactic sessions are used to discuss the skills with the caregivers, but the vast majority of the session involves the clinician providing feedback and instruction to the caregiver as he or she interacts with the child. This collaborative process allows for a discussion of barriers in the home and the development of solutions that utilize the skills being learned in session. Although attachment theory forms part of the theoretical foundation for PCIT, PCIT is primarily promoted from a social learning behavioral theoretical framework. The purpose of the study was to examine PCIT's effectiveness for increasing positive parenting skills, reducing children's behavioral problems, reducing parent stress, and improving the parent-child relationship with a sample of children typically considered in need of attachment-focused therapy. The hypothesis was that there was going to be significant improvement in all areas from pre to post treatment, which include increasing positive parenting skills, reducing children's behavioral problems, reducing parent stress, and improving the parent-child relationship. The methods section, so the sample consists of clinic-referred pre-adoptive and adoptive parent-child diets considered high risk because of the child's history of maltreatment, which increases the likelihood that the children will have less optimal attachment to the caregivers. So there were 85 children referred to PCIT for treatment of their disruptive behavior problems and difficult to manage behavior. And 85% of there were 85 children. There were dyads of children from 2 to about 8 years old. There were adoptive or pre-adoptive parents that also composed the dyads. 51% of them were male, 45% of them were Caucasian. All children experienced early adverse experience such as maltreatment or exposed to interparental violence. Close to half of the children had suffered more than one type of risk, which included physical abuse, neglect, sexual abuse, or had been exposed to interparental violence. The remainder, 30% of children who had not been maltreated or exposed to violence had been prenatally exposed to drugs. The parents, 88% of them were female, most of them were married, and most of them were Caucasian. The methods section continued. So the treatment setting was at a university hospital-based outpatient clinic. The procedure were that parents were given a battery of standardized measures and a short demographic questionnaire after they came to the clinic for the first time. Parents were asked to complete the assessments before beginning treatment. After the first phase of treatment, which was the child-directed interaction, and immediately post-treatment. Additionally, therapists conducted a videotaped 15-minute semi-structured observational assessment of the quality of caregiver and child interactions. The parent and the child played together at a table in a room equipped with a two-way mirror and were concurrently videotaped. The parent wore a bug-in-the-ear device so that they could hear the therapist from the other side of the two-way mirror. Dyads were considered to have completed treatment after parents mastered the skills taught in both the child-directed interaction and the parent-directed interaction portions of PCIT, and children responded to their parents' efforts to manage their behavior. So the analysis, there were numerous measures used to collect the data for analysis, anything from child behavior checklists, the iBERG child behavior inventory, parenting stress inventory, family risk factors, and the dyadic parent-child interaction coding system. The results of the analysis showed significant improvements in internalizing and externalizing and total problems, as well as significant improvements in intensity and number of behavioral problems. And findings reveal significant reductions in adoptive parents' reports to every scale measuring different aspects of their children's emotional and behavioral problems. The results of this analysis showed strong significant increases in verbalizations communicating positive attention, such as praises, reflections, and strong significant decreases in discouraged verbalizations. Results of the analysis showed significant improvements in parental distress, parent-child dysfunctional relationship, difficult child, and total stress scales. So the current paper demonstrates how PCIT, a recognized and commonly cited evidence-based treatment, satisfies 4 tenets of attachment-focused treatment. 1, it focuses on establishing an adequate relationship with the discriminated attachment figure. 2, it enhances the caregiver's ability to sensitively and effectively identify and respond to the child's emotions and behavior. 3, it focuses on the present relationship and context and attempts to improve the child's functioning within his or her current context, and it is also cognizant of the child's cognitive ability. Through these treatment positions, theoretically, one would expect an improved parent-child relationship and subsequent improvement in the child's emotion regulation, self-perception, and social skills. So there is a huge strength in this for this study, and that is that PCIT was able to prompt improvements in attachment-related areas and did so with a high-risk sample, which was the adopted children with a history of maltreatment. There was a limitation to the study, however, because the measurement of attachment-related constructs, such as internal working models or attachment classifications, outside of toddler and preschool age groups are difficult as a result of significant challenges in the development of psychometrically sound assessment methods. A more convincing demonstration of the effectiveness of PCIT for this population would require a randomized controlled trial. It may be necessary to conduct follow-up assessments to determine if behavioral and parenting improvements noted for PCIT translates into more adaptive attachment representations and relationships. So in conclusion, PCIT, which possesses significant improvement of behavioral problems and targets attachment-derived treatment goals, may be the optimal treatment for adopted and or foster children with behavioral and or attachment disturbances. Here is my reference. Thank you.